So I'm going to, if I can, there we go. I'm going to speak about a framework for going from evidence to decisions. And the logic here is that the first step in before you implement a recommendation is getting the recommendation correct. But there's also a number of considerations that guideline panels can take into account as they go from evidence to a recommendation that can help to plan implementation of recommendations, and I'll speak to those. So I'm going to talk about the purpose of the evidence to decision frameworks, the structure, and the use of the frameworks. Many of you, I understand, work in guidelines panels, and so you'll be familiar that often these are large groups with very different backgrounds who come together to make the recommendations. There's often a lot of complex information, little time, and people often come poorly prepared. There's usually a lot of discussion. Sometimes there's voting. Sometimes there's formal consensus processes. Sometimes informal processes are used. Often individual voices at these meetings will dominate the discussion inappropriately. New information is often introduced in the middle of a discussion that isn't part of the background documentation that everybody's received. And everybody's frequently not on the same page at the same time. Sound familiar? So the purpose of the ETD frameworks, evidence to decision frameworks, is in part to address some of these problems by ensuring that panels consider each important criterion for making a decision, providing the panels with a concise summary of the evidence for each of those, for the judgments that they need to make about each criterion so that they make informed judgments as they go through the criteria. And it can help to structure the discussion that panels have so you can have a much more structured discussion. And in fact, although it appears more complicated perhaps at first, you can save a lot of time by going through these criteria and the evidence for each criterion in a structured way. It also makes the judgments and the evidence used to inform those judgments much more transparent to the target audience, the end users, whether those are clinicians or policymakers. It enables them to understand the judgments that were made by the panel and the evidence to inform those judgments. It can help those people decide whether or not to implement or adapt the guidelines that are made in their particular setting, and I'll come back and say a couple more words about that at the end. And in particular, the issue of facilitating adaptation are recommendations. And I should point out at the beginning that there's a set of frameworks for different types of decisions or recommendations. And that's why when I'll use some screenshots from the Interactive Evidence to Decision Framework tool, which is a freely available tool that was developed by the GRADE Working Group and the DECIDE project to facilitate using these frameworks. And the frameworks differ in that they're frameworks for making coverage decisions, that is, what does insurance pay for and doesn't pay for making policy decisions or public health or health systems decisions where it's a group of people making a decision about how to do things on behalf of a population, as well as clinical recommendations, which will be the focus of this talk. And the clinical recommendations can either be from an individual's patient's perspective, from a population perspective. I'll come back to that. And it may also be about a diagnostic intervention rather than a therapeutic intervention where there's a different set of considerations that have to be taken into account. So the structure of the frameworks is pretty simple. It starts with the question, and like any research or any use of research, the key step is getting the question right. Then going through an assessment by considering the criteria that are relevant for the particular type of recommendation or decision that's being made systematically in a structured way. And based on that assessment, making conclusions about what to do and about how to implement the recommendations or decision. So starting with the question, I'm now using screenshots from the interactive summary of interactive evidence to decision frameworks tool. And the example I'll use is whether or not bedaquiline, a new drug for tuberculosis, should be used in addition to a standard WHO regimen compared to using the WHO standard regimen alone for patients with multi-drug resistant tuberculosis. This is a global problem. It's particularly a problem in areas where there's high incidence of tuberculosis, and it's a growing global problem. And the first step then in getting the question right is what many of you will be familiar with, the PICO, specifying the patients of interest, the intervention of interest, the comparison, and the main outcomes. And so in this case, the main outcomes of interest to both patients and policymakers are cure, whether or not patients are cured of their tuberculosis, whether there are serious adverse events, and mortality. And I'll say something about each of those outcomes. Some additional considerations that often get overlooked by guideline panels are the setting that the recommendation is tailored to. In this case, the example I'm using is from a WHO recommendation, so it's a global recommendation which introduces additional problems because of variation across settings, and it's intended for use in multiple drug-resistant TB clinics. Importantly, what's overlooked frequently is the perspective that's being taken by the guideline panel. And in this case, it's a population perspective that's being taken, and the implications of that are that if you're taking a population perspective, you're going to be concerned about all of the costs to the level of population that you're interested in. So if you're taking a Ministry of Health perspective, you'd be interested in the cost incurred by the Ministry of Health. If it's a hospital perspective, the cost incurred by the hospital or the region responsible for the hospital. Whereas if you take an individual patient perspective, from the patient's perspectives, what's of concern are the out-of-pocket costs. The costs to society don't play a big role for most of us when we're making a decision from a personal perspective. And sometimes the outcomes may differ, so from a population health perspective, we're going to be very concerned about increasing resistance to these drugs. From an individual perspective, that may get less weight in making a decision. So specifying the perspective that's being taken is critical in terms of considerations of cost, and it sometimes also influences consideration of outcomes. The other area that often gets overlooked in formulating the questions is consideration of specific subgroups. Often this is done in an ad hoc way after a panel has started its deliberations. In this example, a particular subgroup that was of concern are patients with extensive or extreme drug resistance, where they basically are resistant to the standard regimen, where the recommendation may differ from what it is for people who are newly diagnosed and not resistant to the standard regimen. So moving on to the assessment, this slide's a bit hard to read, but basically for making a clinical recommendation from a population perspective, we suggest 12 criteria that should be used, and most of these will be familiar to you. So the first is whether or not the problem is a priority. The second is how substantial the desirable anticipated effects are, the benefits. The next is how substantial the adverse effects or harms are, undesirable effects. What's the overall certainty of the evidence? Whether or not there's important uncertainty or variation in how much people value the different outcomes, the benefits and the harms. And then the next is really a combination of the previous four criteria. Does the balance between the desirable and undesirable effects favor the intervention or the comparison? And then moving on to resources, how large the resource requirements are, the costs, how certain the evidence is for the costs, and whether the cost effectiveness of the intervention favors the intervention are the comparison. And then considerations about are there impacts on health equity, which may influence a decision in one direction or the other, depending on what direction those impacts are. Whether or not the intervention is acceptable to stakeholders is rarely a reason to change a recommendation, but is frequently a reason for considering how to implement a recommendation. And lastly, the feasibility of the intervention, which is critical and gets directly into issues of implementation, so important barriers to implementing the recommendation. And it's a huge problem when this is ignored by panels. So for example, when NICE in the UK recommended cognitive behavioral therapy for a wide range of patients, it was an evidence-based recommendation, but it made no sense to general practitioners in the UK because they didn't have access to cognitive behavioral therapy. It wasn't a feasible recommendation. So that while you might argue it's an important recommendation to make to policymakers in order that you increase that capacity, it's not helpful to make that recommendation to GPs who don't have, it's not feasible to implement that recommendation. So for each of these criteria, there's a structure that begins with the research evidence that informs the criteria, and Pablo will speak more later about the use of a layered approach, so that what's presented here is a summary of the key evidence to inform this judgment. There may be additional considerations in addition to evidence from research. There may be other types of evidence, for example, evidence from routinely collected data, and there may be logical arguments that are used to explain how the panel got from whatever evidence was available to their judgment. Then there's the judgment itself. So for each criterion, the panel needs to make a judgment that's informed by that evidence, and they may or may not elect to use the detailed judgments, and I'll come back to that in just a second. So what I'm showing you here is that in this first slide, I'm presenting you the consensus of the panel, where the panel agreed that this was a high priority problem. It's a major problem around the world. But what the interactive evidence decision framework tool enables you to do is to vote and to present the judgments in different ways to the panel and to your target audience. So here you can see I'm the only one who has voted, but using this tool, for example, you can, to save time, get the panel to vote online, can provide all of the panel members access to the evidence and the frameworks, and they can vote. And then that allows you to use your meeting time much more efficiently, because you'll immediately see where there's disagreement, and you can focus on areas of disagreement and not spend time discussing areas where there's broad agreement. In terms of the detailed judgment, it includes both an option for the panel to record key messages from the discussion so that people reading the guideline can understand the thinking of the panel that went into their judgments. And there's some detailed criteria for each of the other criteria, for each of the main criteria. So for example, here, determinants of whether or not a problem's a priority includes whether or not the consequences of the problem are serious. In this case, they're obviously very serious. Whether the problem is urgent, and whether it's a recognized problem based on political or policy decisions. And any of these can influence the judgment about whether or not a problem is a priority. So moving on then to what often is the key information that you're probably all used to looking at, evidence about the effects of the intervention. In this case, it's a complicated picture. There's only 2 small studies of bedaquiline compared to a standard regimen for multi-drug resistant tuberculosis. There's a large effect on the cure rate, so 26 more patients per 100 are cured by the end of the study. But there's also an increase in serious adverse effects. This drug is both hepatotoxic and nephrotoxic. So there's 5 more patients who will have a serious adverse effect. And 10 more patients in the data that's available died when they were given bedaquiline compared to the patients who received the standard regimen. So an increased risk of dying despite the much higher rate of the cure rate. So clearly they're important, very important benefit here. It's a substantial benefit, but it's also substantial harm. And there's very low certainty of the evidence. Both because of the risk of bias, but most importantly because there are so few data to inform this judgment at the point of time that this was considered, which was about a year and a half ago. So having gone through the judgments, the next step is to look at a summary of the judgments that were made for each criterion. Based on that, to come to a recommendation, provide your audience with the justification for the recommendation that was made, any subgroup considerations that are relevant, and implementation considerations about monitoring and evaluation, and research priorities. So here's a summary of the criteria that drove the panel's thinking for this particular recommendation. It was clearly a high priority problem with large desirable effects, but also large undesirable effects. The certainty of the evidence overall was very low. And although here's where the subgroup consideration became very important, for patients who are newly diagnosed and don't necessarily have resistance to all of the drugs in the standard regimen, there seemed to be not much, there's very little evidence about these values. This is a judgment of the panel, but their judgment was that probably none of these patients would elect to take this new drug because it increases your risk of mortality. You have an alternative, the standard regimen, and if you're not resistant to that, why would people want to take the risk with this new drug, with all the uncertainty and possibly a higher mortality? Whereas for patients who have extreme drug resistance, they felt that here there's important uncertainty about the values because they really weren't sure. Patients might make different choices. Some might choose to take the new drug because of the increased cure rate and the uncertainty, despite the uncertainty of the evidence, being willing to take the risk, whereas others might not. So this led the panel to make a recommendation as a weak recommendation or a suggestion that's conditional. And it was provisional because there was very limited evidence, and they felt this should be reviewed again after a year when new evidence might become available. And the recommendation was essentially only to use bedaquiline in very specified conditions where there's extreme drug resistance, patients are properly informed, and you have the conditions to monitor both kidney function and liver function. And here you can see they've indicated the criteria that they felt drove their judgments, their decision about the recommendation. It was the importance of the undesirable effects, the lack of certainty about the evidence, and the uncertainty about the values for the patients with extreme drug resistance. And they've given the rationale here so you can get a very quick picture of what's behind the recommendation. And a summary where they've explained both their thinking and, in this case, pointed out that there was disagreement in the panel where most of the panel members felt that the benefits outweighed the harms in extreme drug resistance, but there were 4 who disagreed with that and 2 who abstained. Given this very poor quality evidence, it's perhaps not surprising that there was some disagreement. The implementation considerations that this panel came up with are really less about how to implement this in a particular setting in terms of the barriers that need to be addressed, but focus on important considerations that need to be taken account of in implementing this, including having a proper informed decision-making process, adequate capability to monitor and manage comorbidities, especially the cardiac, nephrotoxic, and hepatotoxic risks, and to have appropriate reporting of adverse effects in order to monitor these and reduce the uncertainty that exists now about the adverse effects of this drug. So monitoring and evaluation is clearly critical in this situation. Monitoring, most importantly, resistance to the TB drugs, and adherence to bedaquiline is going to be critical in terms of ensuring that there's not a rapid rise in resistance to this new drug. Lastly, I just want to mention quickly some issues about adaptation. So you can see here how, particularly with a global recommendation, but also with national recommendations, given specific circumstances in different settings across the country or across different countries, you may, for good reasons, make different decisions in different countries. And so what I'm showing you here is one output of the evidence to decision, interactive evidence to decision frameworks, which is called a policymaker's export version, and Pablo will speak a bit more about this in other presentations that you can generate from this tool. And what it allows you to do is to take a national guideline or a global guideline like the WHO guideline and to go through it step by step and review those judgments in your own context, taking into account local evidence that will inform the judgment in your own context. And so here the example I'm showing you is from a workshop in EMRO, the EMRO region of WHO, the Middle East. And you can see here just one of the steps in going through the assessment where the guideline panel made the judgment that the balance between the desirable and the undesirable effects probably favors the comparison, that is not using bedaquiline. And here you can make a judgment in your own setting whether you agree with that judgment or for some reason, some difference in your particular setting, you disagree. And you can go through then very quickly, decide whether or not there are reasons in your setting where you might make different judgments, and then decide whether or not you are going to adopt the recommendation as it is and implement it as it is, or adapt it and modify it due to specific local circumstances. So that's all I'm going to say for now. I think we'll hold questions until after Pablo's spoken. Thank you.